It's a pleasure to be here. I'm Teri Schreiner. I am a child neurologist in Denver, Colorado, and I have a subspecialty in neuroimmunologic disorders like transverse myelitis. I'm going to practice getting rid of the transverse. That's going to take some time. This is my second time at the symposium, and it's such an honor to be here. This is a forum that I feel so strongly about because as a clinician, one of my frustrations is there's never enough time. There's so much to talk about and just never enough time to get at everything, all of the questions that come up. And so this is a nice complement to what you have established already with your clinicians. I'm so happy to be part of it. So Dr. Greenberg has laid the foundation. He's a tough act to follow by describing wire 1 and wire 2, like our organization of our central nervous system. And that's going to come up again as I go through my topic, which is acute flaccid myelitis. And I was excited to see many people raise their hands when he asked if you had heard of this entity, acute flaccid myelitis. So it's a relatively recently described entity, which has probably been around for a long time. But let me get started and we'll talk more about this. So I do have some disclosures, which means that I work with a lot of companies, primarily in the area of multiple sclerosis research. And here is my outline that is not my presentation for today. This is my presentation from yesterday, which was a great presentation. But I wonder, is Sam still here? He has my presentation for today, and maybe while that gets sorted, I will start this presentation because it's still pertinent. I'll talk about a case first, and that's always a nice way to sort of introduce a discussion, and then as we get my presentation sorted out, we'll go forward. So this is one of the patients that I met last fall. Who was one of the patients that kind of got us thinking about this new entity, or newly described entity. So he is DH, and he is an 18-year-old. He was a senior in high school at the time. Had a history of asthma. Okay, I got the thumbs up. So then, I'm going to have to go quickly then. Who had an upper respiratory infection, as commonly happens in the fall, and developed a sort of abnormal feeling in his throat. He said it felt kind of swollen. His voice changed. He was having difficulty swallowing, and went to the emergency department, and not uncommon from what you have all experienced, I think, was sort of sent in one direction, which was perhaps not the correct direction, but went to ear, nose, throat and received one diagnosis, but then his clinical picture changed, and he woke up with arm and neck weakness. And so I'm going to just summarize this slide to say that he had a particular type of weakness, which was sort of a loose, floppy weakness. So the areas in his body that were the weakest were kind of floppy. And he had an MRI that was distinctive. So as we think about the spinal cord, we think about where we see changes and whether or not they pertain to wire 1 and wire 2. So let me see if I can show you here. See that long white stripe? So this is the spinal cord here, and we're looking at it from the side, and that long white stripe is the area that's abnormal. And when you sliced him this way, we see that there are some white spots here too, in a particular area of the spinal cord, which is the nucleus, the hub of wire number 2. Okay, and I think we're stuck, which might mean that it's time for loading my next presentation. All right, I'm just going to talk to you guys, and they'll figure that out. So he presented, he had this particular type of weakness, this floppy weakness. He had an MRI with very distinctive findings, and he had weakness not only in his body, but of his muscles, the muscles of swallowing. And he became is one of 12 patients that presented with very similar findings last fall. Okay, this looks like my presentation. Let's try this one. Okay, great. Oh, I'm so excited. Okay, so this became known as an outbreak of acute flaccid myelitis, but acute flaccid paralysis defines the type of weakness, that sort of floppy, loose weakness. And I'm from Colorado, and this was one of the places in the country where we had a disproportionate number of these cases, and so we spent a lot of time working with the CDC trying to figure it out. And so I've already mentioned we had 12 patients. They were pediatric, and they all presented after having had an upper respiratory infection in the days to up to 2 weeks preceding. They had this particular type of weakness, this loose weakness. They had, many of them, cranial nerve dysfunction, which just refers to a sort of weakness of particular muscles that are fed by nerves that come right off of the brainstem. They weren't confused or sleeping a lot. They were, thinking themselves at their baseline. There was no encephalopathy, and they had cells in their spinal fluid. So all of this and the MRI sort of painted a picture of a very distinct subtype of myelitis. We came up with a case definition that summarized these findings there. And then we worked with the CDC to try and figure out whether or not this was happening in other places in the country as well. And the CDC came up with a slightly different definition that you see there on the right side of your screen. They specified that it was pediatric, or at least less than 21 years of age, with this particular type of weakness, and the MRI that was very distinctive. Now, one of our first thoughts was, what's different about these 12 patients? Do they know each other? Did they all go to the same school? What could be causing the 12 of them to present with this very distinctive finding? Is there anything unique to them? And truly, we haven't found anything in their environment yet, or meaning they came from different places. As you see, they came mostly from around the Denver area, but this is a big state, so they weren't going to the same school. They didn't know each other. We had one patient in Wyoming, which is that top pink box. And as we worked with the CDC, started trying to unravel this, we realized it was not happening only in Colorado. It was pretty much all over. And, any questions? I'll take a pause. No? Okay, so that is what I'm calling sort of outbreak 1, this outbreak of a very particular type of weakness in the acute flaccid myelitis syndrome. But it happened in the context of another outbreak, which was an outbreak of respiratory disease. So many of you may have been sick last fall. I know I sure was. And many millions of people throughout the country were as well. And they were sick with a virus that has been around for a long time, but previously has not caused big problems, called the enterovirus D68, one particular, subtype of enterovirus. And pardon me for 1 minute, you can admire this map, the big blue stars, Colorado. And truly, the dots on this map do not represent all the people that were sick with this respiratory illness. It was prevalent. When we looked at our institution and tried to figure out whether or not these two outbreaks could be related, what we saw was a graph that sort of overlapped. So let me see here if I can show you. These brown, or I guess gray bars here, represent the cases of acute flaccid myelitis, these 12 cases with the distinctive weakness and pattern on MRI. All of these lines over here represent different viruses that we were detecting in the patients who showed up to our hospital who were ill, particularly with respiratory symptoms. And what you see is around the time that we saw all of these acute flaccid myelitis cases, we also had this spike here, and that spike was in rhino and enterovirus. So this is we gave them a test that doesn't distinguish between these two types of viruses, but you see that was a pretty big spike there. Whoops, there we go. And they seem to have a similar shape. Working with the CDC, we saw that on a national level, now this is data that's only become available recently, but as we look back, they found similar things, that around the time that the spike in enterovirus D68 was happening, whoa, there we go, we also had the spike in the number of cases of acute flaccid myelitis. So we had these two overlapping outbreaks. But was this the first time that we had seen patients like this? And it turns out, no, we had seen this before. So here's a graph from one of my colleagues that shows in California, back in 1962, they described this virus, that enterovirus D68. And then, look, 2012, they started seeing the cases that were sort of referred to as polio-like because of this description of the flaccid weakness. And they started keeping track of those cases. So by the time the outbreak happened here in August to really October, November of last year, California had already been on it. They'd been tracking these cases for a couple years. Their case definition was a little bit different, but I think really in essence was trying to get at the same syndrome, the same observation. And they had reported last fall 23 cases. The number is now up in California specifically to closer to 35. So we had this outbreak. We recognized this came up with a new term, acute flaccid myelitis. But we considered a lot of other diagnoses as we were going forward working up these children, and one of them was acute transverse myelitis. Again, this term that we're trying to further describe, understand, categorize, but what has been a term that refers to inflammation of many different etiologies in the spinal cord. We thought about NMO because the lesions were very long in the spinal cord. We thought about ADEM. Dr. Greenberg mentioned Guillain-Barré. That was on our list as well as another entity sort of similar but different. And then some viral infections that can cause these types of problems in the spinal cord. And we did a lot of different studies to try and understand how this entity differed from others. And as I showed you before in that first case, we saw some pretty distinctive findings on the MRI that helped us to feel like, yep, this probably was something distinctive, something that seemed to involve the nucleus, the hub of wire number 2. So let's talk a little bit about treatment, which was the goal of this presentation. We initially treated our cohort of patients in Colorado with medicines that we often use when we think there is immune dysfunction. The immune system is overreacting. So we used high-dose steroids. We used plasmapheresis, which is a blood cleaning procedure. Many of you may know these terms. IVIG is intravenous immunoglobulin pooled antibodies. And then we even tried this experimental antiviral drug called pocapavir. And that was to try and see whether or not, if these two outbreaks were related, we could improve outcomes by treating the virus. And unfortunately, none of them seemed in the short term to make much of a difference. So so the CDC convened a large group of experts throughout the country to try and do some research and figure out how best were we going to be able to treat these patients based on what we know about how these medicines work in other patients. And so we produced this large document, which I'm going to boil down for you. So step one, don't forget to take care of the patient. These are sort of, general acute management guidelines, and that's good to recognize all that. Step number 2, therapies and interventions. The group really came out sort of I'm going to simplify, on the fence about whether or not steroids or this blood cleaning procedure were really going to help. They felt like this intravenous immunoglobulin, that might help. Based on what we know about how it works, what it's been used to treat in the past, that might be a benefit. And this other thing, these other category of drugs called interferons, they said, no, don't worry about those. That's not likely to make a difference. And then, and perhaps most importantly to this group, they said, let's not wait to start therapies. Let's get them going soon, because that's potentially going to make the most difference. And now, a year later, I think they were correct. The group did discuss antiviral medicines, but it was determined in the course of this outbreak that they really were not effective against this virus. So how have our patients done? We're now a year out from this outbreak in Colorado, or really throughout the country, of last year. And what we've identified is that the course of acute flaccid myelitis looks something like this. So we have a prodromal phase, which is when the patients got sick. They had typical symptoms of an upper respiratory infection, cough, fever, runny nose, and then they got a little bit better. Their fever went away, their symptoms abated, and then the neurologic weakness, the symptoms began 1 to 10 days later, and now we're out here in the recovery phase. So we in Colorado have been tracking our patients' recovery and trying to do it in sort of a quantitative way so that we actually can sort of compare the patients to themselves, how they looked at onset and how they're looking now, but also to try and maybe even make some conclusions about how they're doing as a group. And so we're using different measures and physical therapy and occupational therapy scales, and then also questionnaires that both the kids and sometimes the parents are filling out to get at sort of how they're functioning in their lives, because it's not just what your number is on this score, but whether or not you're finding it easier to function in your life, whether or not you are working better, whether your mood is better, your fatigue, pain, etc. These are the different scores that we used. And so what we found is that everybody's improved. But unfortunately, the patients with the most profound weakness have improved in a way that isn't making a lot of difference in their overall functioning. So they're still weak. The patients who had weakness of their muscles of their face and their throat, they're doing the best. They have had improvement. And thankfully, pain has not been a prevalent symptom, though one of our patients has continued to have pain over the last year. So I think I have just a few more minutes. So let me share with you a case, if I may. One of the other patients that presented in this cohort, MC, who is 8, he presented with, you'll see that shorthand there, is cranial nerve 6 dysfunction, which means he was seeing double. And he had both upper and lower extremity weakness. And on his MRI, again, you see that stripe right there. Pretty distinctive change, going all the way up and down the spinal cord. And then as we sliced him in half, you see he's got, not actually, I heard somebody giggle, but yeah. So he's got these changes here, again, in very distinctive places where the wire 2 starts. So here he is now. This is a couple weeks ago, and he's in the clinic. And what I asked him to do was raise his arms as high as he could over his head. And you see he's a pretty happy guy, but he's having some difficulty getting this arm up. And so this is consistent with the type of weakness that we're seeing, is that it tends to be worse closer into the body than it is distal. And there's muscle atrophy associated, and I recognize it's a little bit difficult here to see, but there's been some shrinking of the muscle there. Another case that actually presented a year before, he was 7 months old, and as just an infant, the parents noted that he was just not moving his leg as much. Well, he's now 23 months after his presentation. We saw him in clinic recently also, and you see he's got thinning of this leg. It's not as meaty as this one. It's hyperextended, which means it's bending in a way that it shouldn't. He's kind of rolled his ankle here. And what you can't really appreciate is that this leg's a little bit shorter than the other one as well. So the video showed him in a rear-wheeled walker, cruising around like it's nobody's business, in daycare, working with his therapist, throwing things and, kind of running with his walker to go and get them, to demonstrate that he really is quite functional, but that leg is still profoundly weak. And so I hope that this has been a helpful description to you of this particular subtype of myelitis, and I'd be happy to take any questions if you have any. Yes, ma'am. Okay, great question. Can you go from flaccid myelitis to regular or maybe, tight myelitis? And the answer is yes. And that happens commonly in people who have a spinal cord problem. Initially, they get kind of floppy, but then later, days, weeks later, it becomes kind of tight. And that is different than what we saw. These patients remained loose, remained floppy. Yes, ma'am.
So this has only been diagnosed brought on by an infection, but not by vaccination? Shots or...
Okay, so the question was, could this be brought on by vaccinations? And I'm going to answer that in two parts. One is that because we had these two outbreaks happening at the same time, we kind of think they're related. But that's a tricky business because you have to prove it. So I'm going to give an example that's somewhat timely. So I have a history that involves when it starts raining, I go and buy an umbrella, and then it stops raining. But I can't say that the fact that I bought the umbrella caused the rain to stop. So that's sort of similar. Work with me on this one. I know it's a stretch, but we have to prove that one caused the other. We can't just say that, well, they're both happening at the same time, so it's probably what's going on. But that being said, we kind of suspect that this may be the result of a viral infection. Enterovirus D68 may not be the only virus that does that, but that's an active area of research right now. This does not seem to be related to vaccinations. Yes, sir. Mm-hmm. It falls. Yeah. That's a very good question, and that's something that we do to assess strength, is try and take gravity out of the equation. And so, so if I am unable to flex my bicep like this, but I hold it like that, maybe I'm able to move it this way because I'm not fighting gravity, which is sort of similar to your question. But no, he's unable to hold it up if someone lifts it for him. Yes, ma'am.
Since correlation has been established but not causality, is there anything so far that y'all have done in research that makes one more susceptible to getting myelitis?
Yeah.
The second part of the question is, what is being done to treat it? I mean, I know you tried a bunch of things and they didn't really work, so is that part of your treatment?
Okay. So 2 questions is, why did the people who got sick get sick? And then what are we doing to treat it now?
Yeah.
And so the first part of your question is interesting because we had millions of people who were sick around this time. Why did only those 12, at least in Colorado, or 120 on the national scale, why did they get sick and their siblings and their parents didn't? And that's something we're still trying to figure out, looking at whether or not there genetically have been any changes in those patients that would predispose them to something like this. And we haven't figured that out yet. So that's ongoing. That's a very good question. So the other question, what are we doing for them right now? Well, it comes down to a lot of rehabilitation. Because what we have seen and what we're actively kind of fighting against is contractures, tightness around joints, and also wanting to enhance function. So make sure that we are doing everything that we can to keep these patients doing what they need to do in their lives, even if they have a weak muscle. So unfortunately, we haven't found a way to reverse the weakness per se. But as you all may know, therapy is, and that's liquid gold, so to speak. I mean, it really kind of comes down to a lot of hard work in the end.
So I guess, sorry, are you waiting to find out more about the cause of it to see what possible treatments may work then? Since you tried a lot of the IVSM and a lot of the treatments that work for other
So at this point, we're not doing any more immune therapies because there didn't seem to be any benefit from the immune therapies that we did in the beginning. So as of right now, we don't know of any treatments
kind of just
that,
holding on till, I guess.
well, I guess holding off is one way to think about it, but another way is not doing any harm. So we don't want to give a medicine that could be harmful to someone if there's really no perceived benefit. And so we've tried a number of different things, but now we're in a place where we're really supporting the patients in ways that don't involve medicines, generally speaking.
And with that, we'll hold questions for question and answer session. Thank you, Dr. Schreiner. That was great.